If there's any issues or rescheduling, I will let you know. I mean, so far so good. We do have the cardiology classes. I mean, I'd like to take the cardiology classes on time. Let's just get going. In the beginning of the cardiology, I mean, a lot of people have confusion on cardio, and a lot of people find cardiology a little difficult than some of the usual chapter. It's one of the reason during MBBS a lot of things may not go in that way as expected. So that's one of the particular point. Like in the beginning, I'd like to give you a short demonstration on the SMA note. Like this is how it looks like if anyone joined a little late. Um, you see, some of your note looks like kind of this. So you need to change your view first of all. Okay, so some people may sometimes text us, Doctor, the notes looks disorganized is because your Google Doc thumbnail view might be like this. So we prefer the list view. So in that case, you can find the notes easily. Like M for medicine, it's more easy to find out. So for the medicine, we look for M and the C for cardiology. So in the beginning, I think you'll find the cardiology. So medicine, the respiratory is done, and the cardio. So you can see some of the notes available here already. As you can see, like cardiology, arrhythmia, syncope, congenital heart diseases, ECG file, heart failure, HOCM, myocardial infarction, and cardiology summary chart. Myocardial notes are already given there, myocardial infarction notes. These are in general like some of the popular topic that's been keep tested in MC exam. So some of the pillars we needed to be cleared is like the theory, the recall, the mocks, the question banks, and also like study partner discussions or forum discussions we call it. Like example, there's a group in shared SMC guideline. If you type the word, let's say cardiology, let me give you an idea. You definitely do it when you finish the recall. So example, if you go to the guideline group, this is how our guideline group looks like. So one of the option is this search option. Okay, now what we can do with this search option, or this is a search, right? So when we click like this, so we can say hashtag cardiology. Okay, so if I just type like this and because this group is formed in 2016, so many question has been posted here and there, like many students, many by me. So, you see the questions out there. So but do understand one thing, people usually upload the confusing or tough ones here. It doesn't mean that you will not get easy questions in exam. So this is like the tougher one, like people have confusion, but another way around, the confused one also comes in MC a lot. I mean, because there was confusion, they keep repeating those kind of questions. Okay, so this will be helpful. So you can just keep going. You can just keep going. You'll find many, 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 many. All right, so that's the thing. So hashtag cardiology. So same goes with some of the previous ones, which means like the GIT, because you just finished the GIT and now if you search with the hashtag GIT, you will again find so many questions. I mean, it can be confusing, but with your study partner and this, that, you try doing as much as discussion, maybe give you the maximum chances actually. See, please understand these questions. We keep posting since 2016. So there's so many years of questions. Almost like it's 2025. So almost like 9-10 years we have been keep posting here. Alright. So you'll find like outside the class many other questions, maybe some previously tested. Some might ask me, is this still important? Yes, those because these are recall. So a 5 year back recall question can be tested definitely. Right. So that's up to you, like as much as you can, you do. I mean, it's not like you can actually finish everything. None of us has complete 100% preparation in the exam, right? So as much as we can, we'll do it. Now coming to this point, today we are doing the cardiology. In the cardiology section, I give you some more idea about how to study. Okay, are you guys with me? Please comment in the comment section. Like I'll give you some more ideas. So some people may join, they might be a little confused, like how to study. Yeah, page number, I recommend you to open chest pain from the journal 350 page. But before going to that one, how to study, how to improvise study, how to increase productivity. Okay, how to study for MC, how to increase productivity, how to improvise your studies. I mean, this will be not only here in MC, but the rest of your life it will be helpful. I've been a teacher for a lot of years now. It's been I think 12 years. I've been a teacher. I win some awards in past. After that, I keep doing the MC teaching. So in early life, because of the teaching skills, I used to also train a lot of teachers as well. That's called actually train the trainers program. Okay, so you can believe me, some of the techniques can be really helpful, even though a lot of things are online. But since it's been last 9 years, but still our academy is kind of ranked one, even for the MC1. We have been doing really well. I keep updating the questions all the time. There's other than these batches, we have also separate recall batches. Support service actually in general, and many doctors are passing, and many doctors recommend. I think many of you also came by recommendation or by seeing a YouTube video. All right. So, yes, you are a bit late. I mean, I cannot repeat that one. You can see the recording video. Sorry. All right. So here we go. Cardiology. So we have been not telling much things. We have been just telling what to study, what not to study. And we recommend you to open a 350 page. We'll get into the journal of that. Now here's some teaching plans. Here's some teaching plans. And let's get started. Okay, so here we go. Whenever we study, I mean, we are going to show you now what to study and how to study for MC. During cardiology class, initial 1 2 weeks will give you the time to adjust with our system. Then we give this guidelines usually. So you can see the overview, then theory, then recalls, and then coming to the question banks actually. All right. So that's the thing. All right. Now here you go. About overview, theory, recall, mocks, and the question bank. All right. Great. Now again, the same thing. I mean, in a little bit more um, details. Now you can see theory, like of course we are following the John Mutak. John Mutak and SMA notes are the heart of your study. Okay, you've gone through two systems. So did you realize the main sources of your studies are John Mutak and SMA notes? Do you agree on that point? Okay. Other than that, did you open any book? Like previously mentioned, there was Davidson's book. Like so when I used to study, I used to keep a Davidson open in front of me. Maybe a table which I'm familiar can be helpful sometimes. Alright, it's not like so. Normally, it's more than enough. Like seven notes and John Mutak, these are enough actually. But if you're familiar with Davidson, a lot of you studied Davidson during MBBS or maybe another degree after the MBBS, you have gone through like FCPS, so you're familiar with Davidson. In that case, keep that Davidson, but newly, I don't recommend much that Davidson for you. Okay, is it clear, loud and clear, everyone? Great. All right. Now, and there's another nice book. It's called Master the Board. This is a nice book called Master the Board. So Master the Board is even the USMLE book, but some of the lines are very useful. Like some lines are given bold lines, and this I even see some of the SMA notes sometimes 1 or 2 slides we also use from the Master the Board actually. Okay, is it clear, guys? So generally, again, I'm telling summary. The theory when you study from the John Mutak and SMA notes, side by side, little help we can take from Davidson, just the tables or the master report. Sometimes, if you think this topic looks complicated, then only open that one from that book. Okay, I hope that's clear. Now, next coming is the recall. How much recall and how many recalls we can use? How many recalls we can do? I mean, so that's the thing. So, first of all, the main one of the source you're probably getting is our class. Okay, so in the class we have limitations, like we can discuss like 40 or 50, but those are the classics and the new ones, those are blended. Okay, so if you do those class ones well, because in the classes I tell one recall and I also counter some of the other recalls so that you prepare really well. So in Thursday class, if you do those recalls, that covers like 80-90%, I mean, of your total preparation. Other than that, now the next thing you have to do, you have to go to the forum. Now, forum means what? I mean, earlier, which I just now shown, is the forum thing. Like example, you are doing, you just now did the GIT. So example, hashtag GIT. So if I search, again, there's so many GAT questions will come, so you can practice more. And other than the classes, you can also do some old one, some extra one from the classes. Is it clear to everyone, guys? So the recall is the highest chances. I'm telling you, recall is the highest chances will be testing in your exam, even much more than question bank. Trust me on that one. So that if you do a little new one and an old one, it'll be fine actually. Yes. Someone says, say like Gibson, I studied the 9 years old, it's totally fine, my dear. Okay, I mean, because you are just using the tables. So for the table means mostly clinical features and this stuff, things like that. So it won't be a problem. But talking about the management, main management has to be which one? John Murtagh. I mean the treatment plans, main treatment plans. It has to be John Murtagh or SMNOs or something new like RCGPs. Okay. So always be careful about the treatment part. Like many times you'll see, like if you see John Murtagh 7th edition and 8th edition, few areas like 10% areas, the antibiotic has been yeah. Where to find the forum? It's very easy, my dear. This forum, I'm sure all of you are uh, in this forum. Yeah, let me show. You will find it. This is that forum. I'm sure all of you are there. If not, I'm sharing a link here. You can just join now. Or you can type share your CMC guideline in the Facebook. You will find it. I just share the link in the Zoom chat box. You can send a request. Will be added back. It has 40,000 members, and people keep posting and keep discussing. Okay, even if you are alone, you can use this group for study. Now, coming to the again important point, forum discussion is important, but even though still you need a study partner. A study I have seen, I mean, I haven't published that one in that way, but in my experience, I've seen those have a study partner and those don't have a study partner, the result might vary. Okay, so did you find a study partner yet? I mean, this is an important question. Did you find a study partner yet? Okay, if not, still there is a hope, because we posted in our group that, to find a study partner. So keep sending people friend request or keep messaging, you will find one. This is like, I would say evidence based because I've seen in Wings 19 years, those are having study partner, they did well more in the exam. Okay, great. So, there's the classes, forums, a lot of times solve file and this, that, available in forums and this, that, you can also see. Anyways, mock and question banks. Right? So after Sunday class, now many of you didn't take the mock after the respiratory, so I highly recommend it. If you're not taking one, means you're not fully prepared for that subject, so you need to revise that subject again. So this is very important. So every time, every week, you need to study well and come up with a mock. Actually, we know this is a self-learned mock. You don't find that exciting, but trust me, it's important. When main time will come, we'll be taking the grand mocks for you. Those are computerized, so that you will be really tested under pressure that time. But for now, small ones and explanations are given. Also check. Okay, so some people ask, Doctor, this question bank. One question bank, anyone is enough. One question bank, anyone is enough. Yes. Great. So far clear? I hope so. Next. Now we'll be talking a little bit. I mean, today I mentioned I'll be also guiding you today a bit about the how to study for MC, how to study. Second thing, how to increase productivity. Do you want me to proceed with telling you how to increase your productivity? Do you feel like you could have done better? Do you have that feeling all the time? Do you have that kind of feeling all the time? GIT mock not posted. GIT mock will be posted today after class. Okay. Any question bank is fine. I mean, you don't need to buy one because we'll be posting a question bank. Okay, we'll be posting a question bank soon. So you don't have to buy one. So here we go. Great. Okay, my question was, do you want me to tell more about how to increase productivity? Definitely it should be an answer is a yes. Now, these are all evidence based. I'm being a teacher. I'm being a teacher of a lot of teachers as well. I mean, anyways, things here, a lot of evidence shows that, if you take notes during the class, okay, there's two group of people. One, they think, okay, I'm a consultant, this, that, I'm busy. We respect you. But when you're a student, you have to behave like a student actually. So that includes that you need to sit, you need to attend the classes. Say example at home, with a diary, with a notebook, you're writing down the important points. So a lot of evidence show those takes notes properly and they organize the John Murtagh and this that they did well. And taking notes is always very important. Now, another very, very important evidence-based and which will increase your performance if you have a study group and a study group. Study group means some people make like a 5 people or 10 people WhatsApp group, but not more than that. I'm telling you, if it's like a 40 people group, it will be like a chaos. It will be like a marketplace. No one is actually participating. So if you can make a group like 9, 10 people of a WhatsApp group, and sometimes little question discussion and what's going on here and there. So this is getting the trending things important study groups. And another one is like your heart is a study partner. Lot of the time, we get complaint that doctor, my study partner ditched me. Okay. Anyways, this is life. Even partner can ditch, so study partner is nothing. So, anyways, choose a study partner wisely. That's more important. All right. So, first three very important. Then is coming as a 5 hours of study. Okay. So we do have a uh, rule that 5 hours a day, 5 days a week for 5 months. Okay, because the course is 5 months, 5 hours a day, 5 days a week. I'm not asking you to 7 days to that, but if you can, it's up to you. But one day relaxation is very important. I highly recommend one day because otherwise the time progresses, you'll feel weak and fatigued. Lastly, sticky notes. Now, have you seen a lot of my doctors been uploading pictures like this about like small pictures? Their whole room is full of with things like that. Lots of notes in the guideline group. I'm sure you have seen things like that. Like people are posting their home wall or study wall. I'm sure you did actually, right? So those are like holistic, like you can write down important thing, what to study next day, what is going through. You can post those things in the wall. I prefer study sticky notes like in the wall, the important one, your aims. I usually write these things, my 5 year plans, I always keep it in the wall. Okay, so that's how it works for me. So for MC things, like especially if you study a little bit more, then what is remaining? Okay, from this chapter, this thing is remaining. You can write that one and put in the wall. Okay, that you need to study this topic well. You missed it last time. So if you add those things, it will be better. When it's done, you just turn it down. So this is one way. Like undone works in the wall. Second thing, you make small notes, and if you have a John Murtagh, this small cut piece will maybe something from the class, something from the recall, you add into the John Murtagh. Okay, like when you open the book, there's so many pages you can see. So this is another way increase productivity. Are we clear here, guys? Requesting, please comment in comment section. Those of you who are attending, is it clear? So one is in the wall. If you can, it's okay. You can paint your wall later. Okay, don't mind. It's a lot expensive the MC exam compared to your wall. The MC exam is a lot expensive. You can again paint your wall. It doesn't matter. Okay. Maybe you can buy a hardboard or something like this. I'm just telling you this is really helpful. One more thing, if possible, buy a printer. If possible, buy a printer. Okay, that will be also helpful. Okay, revision is the key to success. So theoretical mock question bank. So revise again and again is very, very important. Revision is the key to success. Alright, now after 2, 3, 4 subjects are done, what you should do every Tuesday after cardiology, you should keep that one day to revise the previous things. Is it clear, everyone? At least one day in a week. At least one day in a week. Okay, these are very important tips, guys. One day in a week, keep for revising the previous. Say you finish the cardiology, then you get into the next topic. Maybe you feel like some part of the cardiology is not done, so you keep a Tuesday for revising the previous. Okay, that is how, if you do, it will give you a big boost up in your studies. Okay, so we'll be going and doing the cardiology today. A lot of important aspects. We'll come back here, so don't worry. All right. Okay, so some forums to use another thing. Um, we do have the guideline group. There are like Amdex question banks. Like Amdex group is been slow now. Actually, it's like it used to be a good group at some point, but people now study more in the WhatsApp group. Most a lot of my because we run the bigger batches in MC, so our students usually prefer nowadays guideline group. Other than that, there is a Amdex group. There used to be more extra files. I'm not related to that group, neither on that group, so no point in texting me about it actually. But other than the question bank, they also have a group. Other than that, none of the MC groups are helpful. Trust me on thing. You will see only marketing advertisements in most of the MC groups actually. All right. So these two groups are mostly is related to study things. Okay, mostly related to study things. In Bangalore, sometimes I post my classes things. I mean, when it's our next course, so that's okay. But in rest other type of MCQs, you will see only marketing posts actually. But here is mostly people wrote the pre-posts actually. Should I explain the other MCQs? Totally unnecessary actually. It will just kill your time. Trust me. Okay, one more thing. Um, you should have a secure Facebook because some of you opened Facebook recently for our classes. So in that case, highly recommended, two-layer of security. And you can type in YouTube. So because if your Facebook is gone, it's troublesome for you. Normally, we don't allow adding any new IDs. So it's troublesome for you. So please make sure your Facebook is safe and secure actually. Okay. Yeah. This is a common in classroom stuff for me. What's the suggestion? Okay. Study partner is number one, of course. So we use Zoom. Yeah. So okay, before going to that one, tough for me suggestions. Okay. 5 hours a day, 5 days a week for 5 months. First 2 weeks will be difficult for anyone. As the time progresses, you will be fine. You will start having more gripping. Increase your study of hour if necessary. Increase the revision if necessary. Okay, so this is how everyone you will be there at some point. Nothing can be perfect in MC. Okay, I mean when even we go to the exam, me, my friends, or later my students, none of them can tell that I have a perfect preparation. It's not possible in medical field. We've gone through the MBBS. We always have that feeling that it's probably not uh, done in that way. Okay, how to attend classes actually? We using Zoom, so I'm sure everyone is familiar with Zoom now. Keep diary for the classes. I mean, this will help you more. Use a laptop and a headphone like this. I mean, still, if you're just with a mobile and not using a headphone, you are not getting half of the things actually. Is John Muthan during class? Is sticky notes? Add them in the John Muthan later. Don't miss classes. I'm telling you again and again. No matter who you are, please do not depend on the recording. It's like totally like bad practice. Totally bad practice. Okay. I, you can if you have exam like maybe in 7 months, 8 months. Later, you can also renew in just 8 months. Or initially, batch fees are like maybe whatever you pay. That the next batches, if you join, is only $50. So for revision purpose, you can come back to us again. Actually, few of the classes may not recognize due to security reasons. Okay, so don't miss classes. Actually, switch off your mobile device during the classes. If necessary, if it's distracting you, maybe your girlfriend. Yeah, ask someone to take care of kids. It's another important. At the time, a lot of people texted that to have a kid and this that. So you manage these 2 days and someone to take care of your kids. Respect your teacher, online teacher, so should be respected as like others. Actually, these are the few things. Okay, so laptop, headphone, coffee, these are mandatory. Feel this is how while study things should be. I prefer like if you have a table, laptop, you're studying, your notepad here, a coffee here, and you're writing like this. This should be the scenario for next 5 months actually. All right. Great. I've been doing well. It's like more than 1,800 has been passed. Now, here's the interesting evidence. Laptop user has more success than this mobile users or tab users actually. If you use a laptop device, the chances are high. I'm talking about also iPad is also included. It's not a laptop device. Okay, it's more like a fancy device for watching Netflix. Okay. Also, those have study groups more successful than the self-study. It's like the two evidence-based thing I mentioned in the respiratory. So these are very, very important. Okay. Are we done, guys? Are we done? Can we start now? Sorry for taking more time, but this is the way to study. This is how to study. This is how to improvise your study. Improvise by revising on the Tuesday. The old thing should be revising on the Tuesday. This is very important. Now, let's get started. We'll be starting with 350 page. We'll be starting with the chest pain. Then we'll be getting into palpitation, arrhythmia, syncope, heart failure. These are the headline bigger topic. Inside there are more things. And let's go into the next page. Yeah, so congenital heart disease, valvular heart disease, aortic stenosis is more important. SMA note also has the aortic stenosis. Also HOCM, sudden death related thing, hypertension, first essential and secondary. Secondary hypertensions are also very important. And congenital heart disease, we have a special slide note. We'll show you that one actually. All right. So we'll get back to that one. So don't worry. So here's the thing and where we will spend most of our time today. Here we'll spend most of our time today. Okay. Are you guys ready? I hope so. Something about the chest pain. Page number 351. This is how it looks like. In the beginning, in the first page, some causes of chest pain are given. I want you to have a look on this page actually. I'll be starting explaining now. Okay, I hope everyone is done. Now, speaking about the chest pain, it's one of the major things. It's because it can be very deadly. The patient can die because of the chest pain. Now, often the major problem of chest pain, is it because of heart? Is it because of the respiratory cause? Is it because of esophagus? Is it because of the GIT? Interesting fact, 40% of the chest pain, which looks like heart attack, ended up with a simple gas problem, like most cases ulcer or ZERD. Right? It's an interesting fact. Some of the pancreatic and this can also mimic like heart attack. Also some of the esophageal, like if you remember last time, which esophageal condition looks like a heart attack? Anyone remembers? It's a counter question. Which esophageal condition looks more like a heart attack? One, ZERD. Good. Anyone else? Boyer is not really because Boyer will be vomiting, retching, and all these things. Esophageal spasm. Other than the ZERD, to remember, esophageal spasm. Okay, great. Good. And if we say central chest pain, what does it mean? Central chest pain. Is it cardiac? Is it respiratory? Is it esophageal? What do you think? When you say the word central chest pain, it's almost cardiac. Yeah, you can say retrosternal as well. Central chest pain. Another cause is a esophageal as well. Esophageal causes are so cardiac and esophageal causes are mostly central. Now the peripheral chest pain may be a little bit in the side or something like that. Those are the mostly respiratory causes. Those are the mostly the respiratory causes. Okay, so this is the basic difference. Now I'll be highlighting a little bit about how myocardial infarction chest pain may look like. Can we tell like that, like sudden, severe, okay, central chest pain, central chest pain. Okay, what is the nature? Crushing. Okay, sudden severe central chest pain, which is crushing in nature. More than 30 minutes, more than 1 hour. What do you think? More than like an 30 minutes, or you can say more than an hour, whatever. More than 30 minutes, fine actually. More than an hour. Radiating, now very important, radiating to arms and jaws. And of course, the fear of death and this, that. Great. Now, is there any association? Associated with? Now, all those things, shortness of breath, you can say, fear of death. Sweating, we should add this one, right? Sometimes you can say palpitation. Syncope can be plus minus. Okay, so those are the associated things. Those are the associated things actually. Is there any relieving factor? Relieved by? Relieved by? Or you can say not relieved by any drugs or rest even. Right? Or even you can say, no, yeah, oxygen. Yeah, whatever. So there's a lot of things like associated factor, relieving factor, right? So this is somewhere a myocardial infarction, chest pain things may look like. Or better to say, like not related by drugs, but maybe related by recent triangle. You can also add that one. If it's in the angina, in that case, GTM may work actually. So these are in general idea. Every chest pain can be explained in that particular way. Every chest pain can be explained in that particular way. Now I'll bring back something for you. Different chest pain according to the positions actually. For example, if I say this thing, chest pain more on lying flat. Before I bring it up to you, can anyone tell me? Chest pain more on lying flat. Any idea, any cases, which one it can be? Chest pain more on the lying flat. I can see. So first of all, I just mentioned about the myocardial infarction. I'm now talking about some of the other very popular one. My word was like, chest pain more or worse on lying flat. Or also with inspiration, the chest pain also increases. This is going more with the pericarditis, going more with the pericarditis actually. Interesting point. We do the ECG. Any chest pain, what do we do next? Like in respiratory cases, we did what? We did the chest X-ray. Cardio cases, we always start with the ECG things and many times the troponin if needed. Okay. Now, chest pain cases and suspected like MI, of course, we'll go with the ECG. ECG will show ST elevation. Now, ST elevation will always indicate it is myocardial infarction, true or false. Answer is false. You also need troponin I for further confirmation actually. And at the same time, is myocardial infarction only cause for ST elevation? I repeat my thing. Myocardial infarction only cause for ST elevation? No. There are many other causes, including pericarditis. Pericarditis. Now, what's the difference? ST elevation in heart attack or MI, like there'll be specific. There'll be specific. Right? Like kind of like a reciprocal actually. So like lead 2, 3, ABS, something like that, or V1, V2, or V5, V6. Alright, it's more like that word reciprocal. Is it the same for the pericarditis? The answer is no. In case of pericarditis, like one can be in ABF, one can be in V1, one can be in V6. So they don't follow anything. Also, the word we use for the ECG of pericarditis is very important thing in the exam. Is a diffuse ST elevation, and in my cases, it's like interrelated. So reciprocal ST elevation, very important factor. Very important factor actually. Yeah. Yes. Nice point. Like diffuse everywhere. Like ST. Now this is one of the thing. And apart from that one, few of the other important causes of this chest pain and very important ED is as well. As you can see that ZERD cases, we last time we learned, so we're not going there. But the classic ZERD, they are obese people and associated with heartburn and the bloating thing. Some cases there can be nausea vomiting, but it looks like a heart attack. And does it respond to PPI? This is the most important thing, the differentiating point with heart and the GIT. That yes, if it's a ZERT case, now you must be heard this thing. If someone is having chest discomfort, often been told by the doctors take 2 PPI immediately and see how it responded. Yeah, because if it's the because of the ZERT, it is supposed to be, yeah, respond with the PPI. Clear? Alright. So respond to PPI. This is important. Next thing that is coming is a endoscopy. I mean to say that same thing is quite an intermittent ulcer. Ulcer which can be aggravated, as I mentioned. The GIT cause, ZERT of the ulcer can lead to similar like kind of chest pain actually. Now comes some of the lung causes. And lung causes we have already learned like pneumonia. There can be breathing problem at the center, chest discomfort. So it may look like cardiac problem as well. Very important pulmonary embolism, even though our surgical topic, we give a little idea in the respiratory as well. The patient after a long flight or after a surgery, patient can develop pulmonary embolism and it will be presented with the chest pain. Now, if I ask spatial history other than the long flight or recent surgery, any spatial uh, thing you want to look forward in the body, in any parts, in the legs particularly, yes. Well, we're looking for the deep vein thrombosis. Often they started with a deep vein thrombosis, then the thrombus dislodge and it comes to the lung. That's how the pulmonary embolism happens actually. Very important. Pulmonary embolism related, one thing let me clarify you, and you'll get to see that one very often in the exam. Uh, so pulmonary embolism related investigations are very important. Starting with the chest X-ray. Some people also say ECG we do because more we want to rule out the cardiac, but mainly it is chest X-ray. Everyone agree with this part. Pulmonary embolism investigation, mostly the initial is chest X-ray. Is everyone agreed with me? Now come the next thing. There's two things, VQ and D dimer as a next step. These two are the next step. ECGs also we do like simultaneously because but it's not the classic for the pulmonary embolism. ECG we do to rule out the more the other thing. But even though we have a ECG finding for the pulmonary embolism as well actually. Okay, but sometimes see in respiratory class we also mentioned in asthma do we need the chest X-ray always mandatorily? In asthma cases do we need the chest X-ray always mandatorily? Not really, but we do it to rule out pneumothorax, pneumonia, other things. So same thing is here actually. We do it more to rule out the other cardiac things actually. Okay, I hope that's clear. So investigation for pulmonary embolism again is a VQ and the D-dimer as a next, like the second layer, and further CTPA to confirm. Further confirmation by CTPA. Up to this, is it clear to everyone? Okay, now pulmonary embolism in some special situation, pulmonary embolism in pregnancy. Okay, now pulmonary embolism, that's for the general, that's for the in general. If pulmonary embolism during the pregnancy, and this is a popular question in MC. Now, in that case, is chest X-ray is normal? Can we do the chest X-ray with caution? Answer is a yes. As per the John Murtha, we can do it actually. Okay. Yeah, with caution because with risk benefit ratio. Doing the X-ray, do you think it's more risky or will it be more beneficial? Saving the patient from the pulmonary embolism, definitely. So the risk benefit ratio. So benefit is more because you are saving that particular patient. Okay, guys, if you have a question, write it down in our inquiries or you can ask me, I'll get back to you on that particular questions if I miss something. Next thing is a VQ or D dimer. In between these two, which one to pick up as a next? Talking about the pregnancy cases. Talking about the pregnancy cases. So we are picking up in that case as a D dimer. And CTP is still further confirmation, of course, with caution we can do. Usually not recommended, but with caution we can do. Again, understand one thing: if a patient does not remain alive, what is the point about pregnancy or all these things actually? Okay, so risk benefit ratio is to consider. Now, sometimes we draw things like that for. So we draw that D as like this. So D for D dimer. Interesting memory. Okay. So just as a cartoon as a memory, D dimer. I mean, see, this is a very big film, and a lot of aspects are there to make a diagnosis. Eventually, if needed, you can go for a CTPA. These questions more applicable if there is doubts. Some cases by seeing the clinical thing and X-ray, most cases we are sure that this is a pulmonary embolism actually. No, it's not reliable. That is the reason, like CTPA for further confirmation actually. Now, this one reference, like some people give me the reference of question doctor in your question bank. Might find this one a little different. Now, see, you need to talk with the references actually. So I'll be telling you, like Australia has so many recommended website. One of them is the imaging pathway. Imaging pathway. Now, if you can see that according to the imaging pathway, this is a suspected pulmonary embolism. Started with the chest radiograph. This is for the pregnant ladies. And then coming is a D dimer. Did you see that? So then coming D dimer, and later you can go for CTP. So pregnant cases, we are going with the D dimer according to imaging pathway. So if your question bank is not always 100%, right? There's 2-3%. Like USMLE world is much higher standard question banks, but the question banks we have for AMC is like not up to that particular mark. Okay, is it clear to everyone? Like next time, pulmonary embolism in pregnancy, if it comes, we will go with the D dimer. Reference imaging pathway. Imaging pathway. This is officially recommended pathway. If you see the MC website about imaging pathway, they have mentioned this is the imaging pathway one. Okay. Now, pulmonary embolism, then another one we are mentioning here. So, X-ray again initial pulmonary embolism in renal failure. Alright. X-ray initial now, is it D dimer or VQ? Now, this time we VQ scan. So this time is more preferred is a VQ. CTP with caution we know. Normally CTP has dye, so CTP normally we don't really recommend. Because CTP we normally don't really recommend. So here we go. In this particular cases, like pulmonary renal failure, investigation, chest X-ray, VQ scan, and the CTP. Is it clear to everyone? Pulmonary embolism investigation properly with the special cases, general cases, pulmonary embolism, pregnancy, are you clear actually? And we were discussing something about also chest pain and just highlighting the investigation a little bit because they will try to trick you with pulmonary embolism in the main exam. So I hope it's clear from now on, right? So patient presented after a long time. Patient is having a surgery and then the patient is having sudden severe chest pain. Okay. So that's a high chances it's a pulmonary embolism. We do the X-ray or VQ scan or confirm by CTPA. We did discuss about the pneumothorax, so you can read it from the respiratory section or the pneumothorax actually. Okay, so we're not going there the pneumothorax and the pneumonia because these two. Are you guys familiar now? Pneumothorax and pneumonia, guys. Are you guys familiar now? Pneumonia and pneumothorax. Please confirm so that we can go for more topics. And we discussed about the ZERT and ulcer as well. You can definitely look that one, but ZERT is still very popular even in the cardiac because 40% of the heart or chest pain ended up as a simple ZERT. Now, another causing of central chest pain because heart and the great vessels is still central. So aortic dissection. Another interesting thing can be aortic dissection. Before I write something, can you mention something else for me? Aortic dissection. We have something called ABC for aortic dissection. Any idea, any cases, what it is? A for atherosclerosis. Well done. If and B for bone. No, not really. Okay. A for atherosclerosis and aging as well. Of course, atherosclerosis and aging. B for blood pressure, high blood pressure. C for connective tissue disorder. That means, did you heard that aortic dissection has relation with Marfan syndrome? Like those people are long hands, very tall, body structure. So Marfan syndrome, and they have extreme flexibility in case of Marfan actually. So ABC for aortic dissection. Aortic dissection related note is already given in the note section. SMA note, you can check that. So as you can see, predisposes to aortic dissection, hypertension. Very risky thing, hypertension. Okay. They also have like chest pain and central chest pain, and it goes directly backwards. So chest pain, okay, like goes directly backwards. Right. So this is the tearing type of chest pain, which goes directly backwards. This is the in between the scapula. Yes. The thing will be in between the scapula, directly going backwards. Well done. So still is like a go straight. Okay. Did you get an idea about aortic dissection? Okay. Now aortic dissection, radiation to the back, and there will be inequality in the blood pressure. That's classic for aortic dissection. Special history, Marfan syndrome. Now, the investigation related to aortic dissection, starting with the X-ray. Now, aortic dissection X-ray and pulmonary dissection, pulmonary embolism X-rays are very popular in the exam. What is the finding for aortic dissection X-ray? I repeat, what is the finding? Now, aortic dissection X-ray, widened mediastinum. Aortic dissection X-ray, widened mediastinum. Let me see. Yes. So this is how a little bit wider. So widened mediastinum for the aortic dissection. Now, how do we confirm? How do we confirm? Any idea? How do you confirm this dissection thing? So further, what we can do the CT scan, that is an option. But the gold standard is transesophageal echo. Gold standard is a transesophageal echo, often called TOE or TEE. Transesophageal echo or TOE or TEE, whatever you say. Great? Clear? So X-ray following the CT, following the transesophageal echo. Remember one thing, in cardiac cases we do the ECG, and furthermore we often need an echo. In general, in cardiac cases actually, often we might need an echo. Are we clear about these important chest pain things actually? Are we clear about the important chest pain things here? All right. Okay. Coming to the John Murtha. So from individual these causes, but you need to think more. So if you want to add some sticky notes, this is the place where you should add extra one. You can add also extra one page in your John Murtha, or you can add some more sticky notes. So those points I just said, if you can add them here, it will give you a good boost whenever you open the chest pain chapter. Okay, so these are the important one that comes in the exam. So you can add a whole extra page. Okay, now coming into the cardiology. Let's see what's inside. Just give a tick red flag pointers, as like in the ZRD there was some red flag pointers with the esophagus. Here's some red flag pointers. Now, for example, if someone is having a chest pain and someone is hemodynamically unstable. Very bad news. Someone is having chest pain and syncope all of a sudden. Red flag. Okay, so this is like the red flag. This is the page, you see a lot of questions being asked. These are more for your MC part too. You have to ask the patient these particular questions. We already discussed about the some of the investigation, page number 354. Like we might need ECG in the beginning and troponin for the uh, myocardial infarction cases actually. Okay? Troponin, or better to say, cardiac enzymes actually. It's not only troponin, there is CKMB, there is LDH. So there are a lot of options available actually. So ECG, some is also chest X-ray ruling out is it cardiac or is it respiratory, and there is also cardiac enzymes. Okay, so necessarily a lot of things out there. Here's more things about the investigation. As time progresses, there is provision for exercise stress test when the patient is stable, and some more other tests are available, including the echoes actually. So in general, some of the investigations are given here actually. In general, some of the investigations are given here. Okay. Okay. I want you to open up page number is 367. 367. Now, before going to that one, are you guys familiar now? 367. Are you guys now familiar with myocardial infarction and the clinical features of myocardial infarction, which I have written in the beginning? Like what are the sudden severe central chest pain, which is more than an hour, associated with, relieved with. Okay, understand about the clinical picture. Are you familiar with the investigation now with myocardial infarction? We're starting with the ECG, expecting ST elevation, depends on which side, like 2-3 AVF or V1, V2 or V5, V6. It's a reciprocal finding. Did we also discuss about some of the other differentials of chest pain? Like if it's not a myocardial infarction, what it could be? We also discussed that particular part. Now, the important part is coming is the management, and management is also very, very important for the exam actually. Now, about the management, it's often called what it is, MONA. Have you heard of this kind of term? MONA therapy or MONA. So, MI management. So, the patient often presented to the nearby GP, unless the patient called us for this, that it happened often that patient uh, presented, patient often presented to nearby GPs or doctor having discomfort with gas problem or what, something like that. So in that cases, the GP see the doctor, the GP see the patient, and they think, okay, it's not good. So they are up to recommending or transfer the patient actually. So initially, what they can give is this some cocktails. We call it. Better word is a cocktail. Mona is what? Mona is nothing but a cocktail. So it's like indicating like morphine, then oxygen, then nitrates, and lastly aspirin. Right. So these are the things like so these are in generally as a cocktail it's been given. Now, sometime in the MC exam they might ask you which one to give in first actually. Okay, so a lot of like confusion in that one. Which one to give first or which one is a priority. So for the general cases, generally, I mean, we learned about the aspirin, giving aspirin all the time, but ideally, I remember the first heart patient I was dealing with. So the same thing we learned that aspirin and this that. So immediately the senior entered and he asked me one thing that did you give the morphine? So sir, I just give the aspirin and morphine. Okay, please quickly. Then he take me to the side. After resuscitation, they say that, see, how do you feel that if a elephant is compressing your chest? Okay, so do you want to remove the elephant first or then you want to treat, what do you think is, of course, like the elephant? Okay, so it's like that. So the painkiller is it's 10 on 10 pain, unimaginable pain, right? So you need to give the morphine first. Is it clear, everyone? I mean, why not picking up aspirin as a first? So giving the morphine like patient is almost dying because of pain. Patient can go into the shock anytime because of the pain, right? So the morphine immediately, you give the morphine shot, the oxygen came up and nitric aspirin followed by. But this is for what? The MONA is specifically for ST elevated MI. Clear, everyone? This is basically for ST-elevated MI cases. General MI treatment is also different, like you need more things, low molecular weight heparin, catheterization, many other things will come, right? But this initial thing will come a lot in the exam. Now, same another thing, if it's a non-ST-elevated, same thing, another term will be given. If non-ST elevated, then is there any name? It's called the Onam therapy, some cases. Okay, so non-ST elevated Onam therapy. Now, what does it mean? The Onam therapy. So same thing, oxygen, nitrate, okay, nitrates, aspirin, morphine. So ST-elevated cases, the chest pain and things pain a bit more prioritized. That's why the morphine. Non-ST-elevated cases, maybe the chest pain is not as severe as like that one. That's why the oxygen, nitrate, these things came in that. Okay, that's what I can guess. Is it clear to everyone? Is it clear to everyone? So we have the two options. One is ST-elevated and one non-ST-elevated. This is for the general doctors to dealing with. Now coming to the more specific terms, page number 367. Sometimes in the option you will be given angiography and angioplasty. Okay, like what is the ideal management? Now the patient presented in 1 hour, within 1 hour into tertiary hospital. I repeat my question. Patient presented in 1 hour. Is there any golden hour? When someone's starting chest pain, is there any golden hour? Like quickly we can, rush into the CS. So first of all, in like first 60 or 90 minutes, first 1 hour basically is the golden hour. And then after 6 hours, still you can treat the patient well. So if the patient presented in golden hour, then you are offered angiography, angioplasty, what will be your appropriate treatment? So answer is basically we are doing the PCI. Basically we are doing PCI, but in order to do the PCI, definitely you will need the angiography as well. So often in AMC, there's this thing given, you can write it down in your journal nota, that angiography, angioplasty. Okay, it's nothing but the PCI or PCI procedure. Oh, good. So here's the 16-minute, highlight this line as well. First line management of this, that, so morphine, onam, it's a little picture of the PCI thing. For sure, in every family there are one, two relative happen to have heart related issues. Anyone in your family died because of heart issues? Is it is a very close one. If it's very close one, in that case, make sure that you also do checkup. Actually, I mean, if it's bit early, actually. Screening programs work like that. Like if there is a heart history in the family, or diabetes history, or any other history, and even cancer history, and died early because of these things, then the screening thing should start a little bit early for you as well. Actually, that's one. Great. Coming back to this one, speaking about non-ST elevated MI, there are a lot of managements of MI are given here, as you can see. You can just have a look. Now, there are a lot of therapies are given, like fibrinolytic therapies, thrombolytic therapies. Here's a special line I want to highlight. If unachievable PCI, some cases PCI is not possible because of patient not presented, patient is not in the or patient in the rural area. So let's assume your patient in the rural area, peripheral area. Now, can you do the PCI at this moment? No, and the patient will take a lot of time to go to the tertiary. You might lose the chance in that case for the PCI or angioplasty, whatever you said in that case. All right. Now here we go. Like if you are not going for the PCI, you are still in the rural area. If you're in the rural area, then what is alternative? Okay, so there's options like thrombolysis, the fibrinolysis. Now, speaking about the fibrinolysis, what can be the consequence of fibrinolytic therapy? Now, I'd like to ask quickly, what do we mean by fibrinolytic therapy? Which drug is given as a fibrinolytic? In Australia, the more popular one is a um, not the streptokinase anymore, the antiplase and all this thing. All right, streptokinase is not being much used nowadays, So antiplase and this that. Why antiplase is over the streptokinase? You can just Google it, you will find it. Yeah. So antiplase. The antiplase. The question is here: if you do the antiplase and then you send the patient to the periphery, patient to the tertiary hospital, can they do PCI immediately? I repeat my question. Doing fibrinolytic now, and you eventually transfer the patient to the city main hospital. Can they do PCI now? The answer is no. They cannot do now actually. So you have to choose. So basically, cardiologist will choose these things. So even local area, there are some cardiologists. So over the phone, the reports, or if you can visit it, even more better. So it has to be a very quick decision, especially the cardiac cases actually. And at the same time, CPA, if the patient is collapsing, you need to, you know, um, keep pressing the heart with the CPR, actually, and if needed, this is shock. This is very, very important. Mm. All right. Is it clear so far, guys? Is it clear so far? That's all the management. So one is a for the GP some management. GP is trying to transfer, then you also need to take some very bold decision whether PCI, whether not doing anything, sending for PCI, whether doing the fibrinolytic. So cardiologist will decide that thing, not as a general residential doctor. Very big decision. Yeah. And if you do the like already fibrinolysis, then you cannot go for the PCI in the main hospital in that case. All right. So this is very, very important. Right. Just few things given. PCI. Okay. What is more bigger thing than the PCI thing? PCI is like the stenting thing, the ring ballooning. If you do the angiography and you see more blocks, sometimes we say like that. If there is like a main stem, left main stem coronary artery is blocked, or 3, 2, or 4 vessels are 3 vessels are blocked, triple vessel disease often we call. In that case, what you can CABG, coronary artery bypass grafting. Okay, so please check the question carefully. In case if they give any angiography finding or not, but if they mention this line like a left main stem coronary artery is also, yeah. So in that case, coronary artery bypass grafting. What are the difference between PCI and CABG? I think we read it in MBBS. If you forget, you can just Google it one time, like PCI versus CABG. But this is of course the open heart, the main surgery is like this, CABGs. Nothing much here. So we discussed about the MI management, discussed about the MI investigation, chest pain differentials. Yeah, some chest pain differentials we discussed too. And of course, followed by aortic dissection, pericarditis, and this thing we discussed. But this is very, very useful. Whatever we are dealing with, if you know this chart well, another one I have shown you earlier, but this is even better. This earlier I have shown. I think this one from the master of the board slide. But here, this one at page number 359 is summary chart. I didn't bring this one early because summary, if it comes a little later, it's more better. Are you familiar now with the myocardial infarction, angina, pulmonary embolism, aortic dissection, and pericarditis, and pneumothorax already from the respiratory? Are you now familiar with these terms actually? Okay, now it's time to get into this. Now it's time to get into this. Alright, guys. So, I mean, this particular thing, I'll let you guys read it for next 4 or 5 minutes, then I will start. So, because we just finished that one, so you guys just read this one in 4 or 5 minutes, then I'll just continue and we'll wrap up this particular section. All right, everyone, thank you. So I hope so you managed to read the slide, but again, I'm giving a very short summary here. Uh, Quickly, before going for the individual discs like myocardial infarction, already discussed. Seven severe central, you see the word crushing, you can highlight. Retrosternal chest pain, radiating, this thing more than an hour, not relieved by anything. So these are classic. And at the end, they have mentioned about the ST elevation and also troponin. That is the cardiac enzymes actually. This is very, very important actually. This is very, very important. Also speaking about the kind of similar thing about the angina, little less extensive than the MI. In angina cases, the good news is the patients are often stable. So that's why, you can do the exercise test, stress test, or exercise test. Those things you can perform. Most cases, they are smokers actually a lot. Even heart issues, we know, are not related to smoking. Anyways, apart from that, pulmonary embolism, we already discussed more like, long flight, and at the same time surgeries. Okay, and these are some of the clinical features. So chest pain is the main one, and breathlessness, of course. Breathlessness, another very important keyword for pulmonary embolism. Spatial history, you can see that long flight, and already mentioned is a small ECG finding is given, but ECG is not so popular for the pulmonary embolism. But if you get that finding, that's like a sure. But mostly you do the X-ray, and X-ray will show you wedge shape opacity. This is the very important context. Pulmonary embolism, they'll give you an X-ray showing wedge shape opacity. This is faster for the exam. Please highlight this line. We are at page number 359. And of course, we already discussed about that one. You should have a sticky note and attach to this particular area. That what is initial, what is next, based on what is for that other spatial conditions like pregnancy and the renal failure. Okay, we discussed it, we're not going there. Aortic dissection is like a tearing chest pain, hypertension, and Marfan syndrome of the history. ABC we discussed. Okay, ABC we discussed. Unequal blood pressure is one of the thing, and X-ray showing. Initially, it's X-ray. X-ray is showing. Please highlight. This is very important. Red color. Something use for these things. Widening of the mediastinum. This is often given in the exam. Okay. Already mentioned aortic dissection will start with the X-ray, then there is a CT scan option, and the gold standard is TEE, transesophageal echo. Please highlight this one as a red actually. Important. And pericarditis, same things like kind of myocardial infarction. They also do have chest pain and this time. ST elevation is also common, but here they have a diffuse ST elevation, pain more on the line flat, but the cause is interesting. Often following a viral fever, pericarditis, often following a viral fever. All right. So which particular viral fever is particularly Coxsackie virus. Okay, particular Coxsackie virus, or they can have a renal problem which presents as uremia. So uremia, then viral, these are some of the common things. Also following a myocardial infarction, say someone has a heart attack, MI. Following that one, there can be this situation, pericarditis, like 2 weeks after myocardial infarction. So a long time complication of myocardial infarction can be pericarditis, as like a Dressler syndrome. Okay. In case of pericarditis, when you hear the heart sound, there will be some kind of rub because of the pericarditis. So that it's called pericardial friction rub. And already we learned about the ECGs. There is ST elevation, but these ST elevations are diffuse. There's a special thing I want to highlight for the pericarditis. There's this thing called down-sloping TP. I'll upload a ECG video. So the ECG video can be helpful to root out and see some of the ECG slides. It's already available in the video channel, but after class I'll reshare that one actually. So there's a thing called down-sloping TP. For now, just write it down, down-sloping TP. Okay, so after the ST is a down-sloping TP, which is not common in myocardial infarctions actually. It's a special band. All right. So pericarditis is ECG finding, down-sloping TP. Alright, and pneumothorax, nothing to tell, already discussed about the pneumothorax. This is the end summary of this big slide. Are you guys familiar now with these conditions? Just telling a little bit more, 356 page, this aortic dissection is given. But it looks a little bit confusing, so I think it's better you read from the SMA node actually. Aortic dissection, I recommend you more to read from the SMA node actually. Yeah. So we will show you. Here is that particular memory about the aortic dissection. Aortic dissection. And we already show you there was a inequality in the blood pressure and hypertension is so common. Tearing type of chest pain, it reduced towards the back. Okay, and a special term was a CT scan. Sorry, an X-ray, widening of the mediastinum. Widening of the mediastinum. There can be more finding in the CT scan. Now, have you heard about things like that? Double barrel aorta. Have you heard about this kind of a thing, like a double barrel aorta? There's some old rifles actually. All right. So old rifles, yeah, this is something. Okay, so it's like double barrel. So double barrel in the CT scan finding for aortic dissection. It's important for the exam. Double barrel, so X-ray and the double barrel. All right. Anyways, nothing much special on that one. Mostly diagnostic and investigation wise things comes. Pulmonary embolism we discuss, it will come again in the surgery. There's sometimes problem with the jaw move that things are not given as we expected. Good news, pericarditis is given, there's some causes given, so please highlight 357 page, 357. Viral uremia post-chemo. I guess aortic dissection one is not given in this note. So please, you can take a screenshot of aortic dissection. It's an easy topic, so nothing much to worry. So aortic dissection. This is another page which showing a Davidson slide. Hypertension is number one and some clinical features including chest pain. And this particular X-ray is important for aortic dissection, which they have the widening mediastinum. And the spatial CT scan is showing double barrel aorta. Okay. Last one thing about aortic dissection. What do you think about the management? So they also mentioned about investigation, but nothing mentioned about management. 356 page. What is the management for aortic dissection? First of all, like if it is ruptured, so you need immediate surgery. Often it's difficult to save the patient. If aortic aneurysm or aortic dissection not ruptured. Okay, and even if it is not ruptured, we'll consider and eventually later we can come up with a surgery. Now, aortic dissection and there's another one, aortic aneurysm. Let me show you something about aneurysm. Okay, in one word, if you want to explain the AAA, abdominal aortic aneurysm or aortic aneurysm. So what is aneurysm is actually? It's nothing but abnormal dilatation of the aorta. Now, the question is, if this is an abnormal dilatation, then usual Is that a good news for the patient? If there is abnormal dilatation, it's not a good news because why? If it's little abnormal dilatation, it can rupture actually. You all will be agreed on that. If it's a dilatation, it's more pressure. Why this dilatation? Because of more pressure, more high blood pressure. So it can rupture. If rupture, patient will die. Most cases. Most cases you cannot take the patient even to the hospital. Most cases they will die. Very lucky people at the hospital, if this thing happen, actually surgeons can save the patient. Otherwise, very difficult that it is happening at the home and you're taking the patient to the hospital and surgeons come and repair it. Very difficult. Now, here's the thing. If it is a stable aneurysm, please take a picture of this one. If it is a stable aneurysm, stable. Stable means not ruptured, unruptured case. Unruptured case um, is always required surgery. True or false? Unruptured case, is it always necessary surgery? Answer is false. It depends on the size. And here the size, first take a picture, then we'll explain. So I'll give you a 15 seconds to take a picture of this slit. Now, I'll have to ask you a Q question. How one of the question has been tested in past? It is actually, it was given 4.2. The size was given 4.2 and it was asked what to do next. Basically, you will do ultrasound to follow. Okay, these are all the findings, the follow up by ultrasound actually. This is abdominal structure, so you need an ultrasound to follow. So ultrasound follow. So if it is 4.2, it is annual follow up or yearly or 12 monthly. So it's like an annual follow up, you can see. So it depends on the sizes. Now, another thing I like to highlight here, if it is more than 5, then what? If more than 5, in that case, it is recommended to go to a vascular surgeon. I recommend if it is more than 5, it is recommended to go to a vascular surgeon. Now, I like to highlight one thing, male and the female, they also have a difference actually because of the body size. So this acceptance to go to vascular surgeon for male, acceptance to go to vascular surgeon for male is more than 5.5. Okay, so 5.5 for male to go to vascular surgery. If it is 5, the size centimeter, in that case to go to vascular surgeon for female actually. So yes, so 5 for female, 5.5 for the male actually. To go and see the vascular surgeon, vascular surgeon will decide the surgery actually. If more than 5, they will consider the surgery actually. I mean, they will tell you the right time. Is it clear to everyone about the aneurysm, guys? Aortic dissection and aortic aneurysm, very risky thing because they can rupture. It's like a dilatation or a dissection is like a tearing. It's related to aorta. It's all related to high blood pressure as well. So they can rupture anytime. They can be related to spatial history, Marfan syndrome. And this is their following up. This is their following up, like, depends on the size, you will follow up the things actually. Okay. So summary again as a treatment, summary treatment depends on the size. If it exceeds the size, it requires surgery. If it ruptured any time, you need immediate surgery. Agreed, guys? If it ruptured, require immediate surgery. Now, interestingly, I'll teach that part in the surgery. If a patient with a suspected ruptured aneurysm, what did you do next? I mean, in the emergency room, you're sitting and the patient entered. What do you do next in that case? Okay, other than the resuscitation, can you do a bedside ultrasound, which is known as a fast ultrasound, FAST. FAST, special type of ultrasound. So you can do, because any ruptured organ, any internal bleeding, we can do the first ultrasound. Okay, and then we can go for that. So first ultrasound, FAST, and then decide going for the surgery. So is it clear for aneurysm, guys? Is it clear for the aneurysm? These type of spatial lines, you can make a small sticky note and attach to page number 356 later. Good? Great. And we talked about the pericarditis. You can check the summary note, summary slide will be enough, I think. Summary means is this one. Yeah, I mean the previous summary. 359, there was a summary given. So you can also check that now. 359 chart for the pericarditis would be enough. And I think if you go here, yeah, we do have some notes. You can also check some of them. Okay. So this pericarditis things and all this thing comes under kind of like the MI, actually, MI chapter or chest pain, better to say. All right. Take a second. Are we clear about the chest pain so far, guys? Just want to ask you all. This is the main one. That is actually the main one in. So we were discussing it. So our main one was like the chest pain, and you will get to see most questions from the chest pain, and another one is the palpitation, actually. So chest pain and the palpitation are the two most important, where you will find most of the questions are coming, actually. Most of the questions you get to see from these two chapters. So for the palpitation, I would recommend you to open 721 page. 721 page for the palpitation. Taking a second. Okay, so when we are reading the palpitation, that particular chapter, it's related to rhythm, the arrhythmias. There are certain conditions like where the rhythm is high, the rates are high that like SPT, VT is like typical some of the other conditions. VF, all right. So SPT, VT, VF, so where there's increased rate. Then the arrhythmia, like atrial fibrillation, basically there will be irregular rate. If it's atrial fibrillation, irregular rate. And in heart block cases, there is decreased rate. Okay, these are in general. These are in general. Okay, let me take a second. Okay, this is better. Okay, so our palpitation, this particular one is a big one coming up. All right. So I think it's highly recommended. Let us go for a break. and then come back and SVT, VT, VF, all these things are given. Page number recommended to open is 721, but we'll go through initially through the note a little bit and then entering into John Nota. Yes, we'll go for because it's cardio class, so of course I don't want any issues for the doctors to happen. Yeah, so let's go for a 10-minute break at this point, okay? 10 to 12-minute break actually. So then we'll come back, SVT, VT. There is also a summary chart like this, and also it also improves the heart block as well. When you're reading the palpitation, it means SVT, VT, VF, and those things are also included actually. Right? Great. So see you all after 10 to 12 minutes of break. Thank you so much. Okay, fantastic. So coming up topic is yes, this one, palpitation. Those of you didn't attend, we haven't uploaded the GID mock test yet, but after today's class, it will be uploaded in a group. Okay, great. For the lab test doctors, of course. Great. All right, so palpitation. So there's few things we like to highlight here with the palpitation. Especially the key term is one of them is arrhythmia actually. Right. So it's a problem with the rate and rhythm. And if you see the word arrhythmia, it's like a puzzle. Inside the arrhythmia, the word rhythm is there. So it can be rhythm up or rhythm down, too fast or too slow. Depends on what is the condition. It can be SVT, it can be VT, it can be atrial fibrillation, it can be atrial flutter. Okay, so these are mostly rate up condition like SVT, VT, atrial fibrillation, flutter. It's like a beat up condition actually, and some condition can be beat down like the heart block. Okay. Some condition it can be rather than saying irregular, rather than saying beat up, we would say irregular, which is like the atrial fibrillation. Right? Some situation can lead to syncope. Some situations can also lead to syncope as well. So we do have a syncope note in the SMA note. You should also all right. Let me, so this microphone is on. Let me turn it off. All right, that's fine. Great. Up to this, everyone is clear, guys. Up to this, everyone is clear. So some of them is rate up, rate down condition. Individually, we have to go through all the diseases now. Starting with the very first one, again, my key term here, it is palpitation. Is all are under the palpitation. Now, you see when there's more beats. So from one peak you are, so from one R to another R, or you can say one T to another T, like distances are reduced. So when distances are reduced, we call it palpitation. If distances are increased, what do we call it? I mean, I know most of you know it, but some people may forget. If distance increased, then what do we call it? If R2R interval increased or PR interval increased, we call it bradycardia. We call it more like heart block conditions, right? So it's tachycardia, it's bradycardia. Some of them can be physiological, like so when we exercise, it can be physiological. Some of them can be pathological, right? So there can be physiological and pathological tachycardia and bradycardia as well, actually. For example, professional athletes are having some cases physiological bradycardia. Some situation like pregnancy can have tachycardia, physiological. So these are some of the situations. Now coming to important things like, let's say, let us take one of the palpitation condition, that is the SVD, expecting palpitation. So key point in AMC, palpitation and spatial ECG finding. Now, of course, palpitation, how do you understand? Distances are reduced, like one distance from this one to this one is reduced. So R2R distances are reduced. Right. Now, what about the QRS complexes actually? One, we can see this palpitation by ECG. When we understand it's a palpitation, but how do we understand it is a SVT? We do have QRS complex. So some QRS complexes are narrow, some of them are wide. So narrow QRS complex with a heart rate more than like 200 often, more than 200 often, this is higher chances a case of SVT. So SVT often indicates palpitation, narrow QRS, heart rate over 200. Next, are you expecting any pre-existing heart condition in SVT? Are you expecting pre-existing heart condition in SVT? SVTs can be common in young as well. Even though a lot elderly also have SVT, but bit early before 50, SVT can be presented actually. So often this question comes in MC, usually given before 50. Okay, so SVT questions usually before 50 given in MC, but a lot of cases are elderly with SVT in real life also presents. Okay, so SVT palpitation narrow QRS heart rate more than 200 actually, and as I mentioned, ages are often given before 50. And in terms of pre-existing heart diseases, usually no pre-existing heart diseases. These things we have to remember for the MC exam. Is it clear, everyone, or do you want me to mention it again? Or move on? Please write it down. Okay. So in that case, okay, one more time quickly. SVT, which is a palpitation condition. QRS complex is narrow QRS complex. Short in ECG. Heart rate would be more than 200. Heart rate more than 200. In the MC question, it will be less than 50, and VF will be given more than 50. Pre-existing heart condition like pre-existing MI, pre-existing other heart problem, like usually no for SVT, but usually for VT or VF particularly pre-existing. Example, it's known as myocardial infarction. Often the cause of death is because of ventricular fibrillation. So pre-existing, heart attack or myocardial infarction is present. Now is it clear to everyone? And basically we're trying to compare and contrast with VF actually here. Okay. I hope that's clear. So basically all those conditions other than the palpitation, QRS will be wide, heart rate will be less than 200 in VF, and pre-existing heart condition like MI would be present in VF cases. Is it clear now, everyone? Like, so we are basically differentiating SVT and the VF here actually, so that we can differentiate in the main exam as well. Don't worry, I'll show you in ECG, it will be more easy later. Same goes with the VF, so palpitation, wide QRS, heart rate less than 200, Usually, a pre-existing heart disease and the age more than 50. Now looking clear to everyone? I hope you do. Alright. Now, if I tell you something like heart rate, I mean, there's ECG showing irregular. Like some of you might be in the classes at some point, irregular. Now, what we're talking about here? We're talking about some situation like atrial fibrillation. Can you tell me about the classic ECG finding of atrial fibrillation? Of course, irregular. Some people says like husband and wife. I mean, no relation in some cases. Okay. Anyways, so in that case, usually missing or absent P wave. Okay. Plus, there is another situation. The familiar term is sawtooth appearance. Did you heard about this name? Sawtooth appearance. That means there's too much palpitation, almost like 300 beats. This is atrial flutter. Please take note, atrial flutter, pre-existing situation like hypertension. So there will be uncontrolled hypertension is a key for having atrial flutter. I hope this is clear to all. Alright. When you're having palpitation situations like this, there's been too much heart palpitation. So as a result of this, there'll be heartbeat issues and at the same time syncope can be present. Clear? Alright. Coming to the point like SVT, palpitation more than this, no pre-existing situations, ECG showing, these are the finding like narrow QRS. Already this is mentioned, now getting more easier. Okay. Some situations can be physiological like sinus bradycardia, sinus tachycardia. Okay. Going forward. There are some situations why we are afraid of syncope. Because some situation can lead to sudden cardiac death. Even ventricular fibrillation can lead to sudden cardiac death. SVT less chances but can happen. Okay. So these are the situations can lead to sudden cardiac death. We do have a ECG finding here. Can you see this ECG and comment on this one? First of all, I can see palpitation very clearly, but in terms of the QRS complexes, what do you think? Is it a narrow QRS? This one to this one's distances are QRS. Alright? So this one's findings here is a very classic. This one particularly, very classic. This one is a ventricular fibrillation. So increased heart rate, so distances are reduced, ventricular fibrillation. So wide QRS, palpitation, and usually we're expecting pre-existing, heart is present, heart rate usually less than 200. So this is like situation is completely disorganized situation. The patient can have syncopes in that case. Alright. Another situation. Yeah, so this one can be ventricular fibrillation. Completely disorganized ventricular fibrillation. Okay. This is summary chart given in this note. This is taken from John Murtagh. But if I show you the summary chart, even in the palpitation chapter, basically we like to go through this summary chart. It's page number 733. I'll give you 10 seconds to open up. 733. I'll tell you a few things from here. It will be easy for you. So add more pages, more slides, more sticky notes nearby to this one particular page actually. Now here you can see a few things. Like earlier one was SVT, there was palpitation, and there was those disease finding this, that. And here they talked about the management. All of them are arrhythmias. So they give like first line, second line, and third line. The management is Valsalva and motor. Okay, or you can say vagal maneuver as well. Is a second line treatment adenosine or Verapath. If everything failed, DC cardioversion. Now, let me give you a situation, SVT condition and hemodynamically unstable. What to do in that case? Atrial flutter and VF are not same actually. In atrial flutter, it would be like way too much, but it would be a bit organized, whereas ventricular fibrillation, it will be disorganized. Okay, it's a good question, man. Okay, so my question was is with PSVT, with hemodynamically unstable. Quick question: how do you understand hemodynamically unstable? Patient blood pressure is less than 90/60. Situations like that. Alright, blood pressure. These things will be quite affected, like then rapid threading pulses. These things can be, but mostly we understand from the question that the blood pressure is given extremely low. This is a very famous thing you should know. Chest pain, shortness of breath, confusion, hypotension. Chest pain, shortness of breath, confusion, hypotension. This is very classic for hemodynamic unstable situation. But for the exam, we check the blood pressure mainly below 90/60. Now, you can say vagal maneuver. Then in the second line, the drugs. Third line, DC cardioversion. My question was, if unstable, immediately DC cardioversion. This is another popular question. So all of this situation, double check the ECGs actually, which I will share a file. Don't worry, I'll share with you. It'll be easy for you. Atrial fibrillation and the flutter and other situations other than the PSVT. So where you need rate and rhythm control. Again, these situations are also tachyarrhythmias, means tachycardia is ongoing. That means palpitation ongoing. You can write in simple term palpitation ongoing. So if palpitation ongoing, so what to do next? Very simple. Ask yourself, if too much palpitation, what to do next? You need to control that palpitation. You need to control the rate and the rhythm. So how to control it? Control it by giving them a beta blocker. Okay. So control them by giving them a beta blocker actually. Okay. That's the thing. So you give a beta blocker, very, very useful actually. Again, same thing. If this situation, the patient is extreme unstable, hemodynamic unstable, you give a DC shock again. So all this situation is unstable, we give a DC shock in these cases. Okay. So atrial fibrillation, atrial flutter. We'll come back to this situation second. When we're talking about the ventricular fibrillation, as we mentioned, ECG showing completely disorganized situation. If you see ventricular fibrillation, you see the first line. Now, is this a vagal maneuver? Is this a drug? No. In ventricular fibrillation, because it is disorganized and life-threatening, so what you need to do next immediately, going for a DC cardioversion. Clear everyone? So ventricular fibrillation, extreme dangerous situation, going for a DC cardioversion. Is this thing clear to everyone? So ventricular fibrillation we just learned. SVT we learned. Atrial fibrillation we learned. Flutter we just learned. Okay, we'll get back to them with more details shortly. So this is the summary chart. This is the summary chart. So are you clear about the summary chart? I mean, heart block we haven't discussed yet, but the tachy ones are, what do you think? The tachy ones are a bit clear. One very popular question in exam, what are the 4 important causes of atrial fibrillation? I mean, you should know it actually. Then I will tell you which one comes in exam very often. Answer of causes of atrial fibrillation is pre-existing myocardial infarction or ischemic heart diseases, then any valvular heart diseases, then rheumatic or valvular heart diseases, and then hypertension, then last but not the least, thyrotoxicosis. Don't forget that term, guys. Actually, this thyrotoxicosis related history is often given with atrial fibrillation. This thyrotoxicosis related history often given with atrial fibrillation, and they ask you what to do next. So what you need to do next is control the rate. Now they have mentioned here the drug beta blocker, but thyrotoxicosis you also need to give a beta blocker, but a very specific beta blocker. The answer for this one is a metoprolol. Metoprolol. Please remember the term metoprolol. Alternative is propanol. Okay, some basics in exam. If mentioned hemodynamically unstable means these are the few terms: chest pain, shortness of breath, hypotension is needed to remember because often easy to identify in the question and confusion. These are sign of hemodynamics. So the management is always a DC cardioversion. This one, actual floater, special term is what? Now, before going to flutter, is this a tachy condition or bradycondition? This is a tachy condition. And there is a palpitation. Is it a usual palpitation or is there too much palpitation? This is a too much palpitation and there is like a sawtooth appearance even. Right? So this is special, and special history is a long-standing hypertension. So if you see deep down of atrial flutter, there is like a so much these things. So treatment of atrial flutter is what? First line, second line, third line. So controlling the rate by beta blocker or calcium channel blocker. Okay. Later, if needed, you need to give DC shock. Later, you need to give, if needed, permanent pacemaker for atrial flutter conditions. Remember, any arrhythmia conditions, if they are not stable in long time, you might need a pacemaker. This one is like a sawtooth. It's like a sawtooth pattern. So atrial flutter, atrial flutter, atrial fibrillation. So let us look into this ECG more carefully. What do you think if anything is absent? Some of them looks like suddenly started and something is absent. So something atrial, something is missing, which is the P wave. And you can also see like one is like this, one is big, one is small. So it's irregular. So we can say irregularly, irregular. So irregular, absent, P wave actually. Suppose fibrillatory F wave they mentioned is very hard to detect fibrillatory F wave. But this is atrial fibrillation. Important causes, myocardial infarction, valvular heart disease, heart valve issues, and thyrotoxicosis. Thyrotoxicosis especially to remember. Now, if the patient is complaining, they have this kind of situation, syncope, and this, that, or history of fall. What test do you want to do next? Checking the blood pressure for 24 hours, or is it the Holter monitoring? A syncope case or fibrillation case, a similar type of case, it's a Holter monitoring. So it can be in the hospital, can be at the home. So palpitation, because of palpitation, there's fatigue because blood is not going in brain properly. So eventually, fainting didn't happen. Dyspnea happened because too much palpitation, the lung is not able to cope up properly. So eventually leading to dizziness, it can be chest pain as well. So in generally, main stem, of course, we do the ECG to rule out what is going on, and eventually Holter monitoring. More tests, you can go for like stress test, echo, chest radial blood test. Four most important causes already mentioned. So atrial fibrillation, thyrotoxicosis, metoprolol. Just mentioned. And stable and unstable cases, DC cardioversion. So there's a thing, first rate control. So when to use which one, there's a little bit guidance is given actually. There's something called with atrial fibrillation chats, like chats coding, chats Any idea about this one? So this is called chairs or chairs. Nowadays chairs was scoring. So let me show you how a chair scoring looks like. Do you want me to show a chair score, or are you familiar with a chair score related question? You know how chair score question comes. Do you want me to show it? Okay. First of all, I mean, this is the idea about the chair score, like CHADS chairs. Now let me show you a question related to chairs. Yeah, because I find like normally chairs scoring is something and the exact question related to chairs can look different. Now, there's a question, I'm not reading it, you guys read it, come up with a quick answer, please. Keep going. Wait for an answer. Alright, a lot of people went for D, some people went for the C. Okay, now, do you think any risk factor? Example, these are some of the risks which related to one point. Do you think these things are present in this question? They mentioned no history of hypertension, this, that particular thing. So that means CHAT score is what here? CHAT score is like a kind of like a zero here. So it means 0 or 1. CHAT score 0 or 1, what is the management? CHAT score 0 to 1 or less than 1, it's a aspirin. 1 or less than 1 aspirin. 2 or more than 2, digoxin, dabigatran or whatever the others, depends on the INR. So this one is this. I'll tell you more detailing things, especially when you go to the pediatrics about the warfarin and their overuse, and very important part. Okay, is this thing clear so far? This question, like this chats thing. Okay. So again, atrial fibrillation or flutter, the management is you can see beta blocker or calcium channel blocker to control the rate. Later, if needed, you can add the digoxin. Actually, if atrial fibrillation present, it's already a risk of what? Risk of producing thromboembolism. So 0 or 1, you go for an anticoagulation. Clear now, my dear? I mean, if atrial fibrillation means you are already in risk for having this particular. So in that case, you need at least something, either the aspirin or either the warfarin in most cases. Clear? Chats is in, or you can Google it, my dear. Chats, you will find it. Very easy. Or eternal is also present. Now it's modified into chats last two. It's kind of same. So arrhythmia, SVT, VT, atrial flutter, and atrial fibrillation. Okay, so most of these are organized, and disorganized is atrial fibrillation. Disorganized is ventricular fibrillation. Clear, everyone? So even atrial flutter, which is like nearly 300, but they are, yes. Is score 0 why aspirin needed? Because it's still chances of, it is atrial fibrillation. Chances of thromboembolism is very high. That is the reason. Great. Still, it depends on the cardiologist. They will comment the most. Here the answer is aspirin. Okay, let's focus here, guys. We don't have to be big cardiologists. It's very straightforward answers right here. Like, see, there's a specialized cardiology section, but that's why it is often we refer. because the cardiologist will take the decision based on so many things. For us in MC Part 1, it's quite a straightforward. You go with the drug, yes. You go with the drug, no. It's most like that. And if there is a heart block, there will be late. Alright. There will be decreased rate in heart block. Okay. So guys, are you familiar with these things now? Are you guys familiar with this thing, the arrhythmias so far, except for the heart block? I'll take you to the heart block section now, actually. But if you say yes with these particular situations like fibrillation, flutter, ventricular SVT, and that actually, then I would like to get into, this thing. Okay. So another situation, which is another arrhythmia, which is decreased rate, that is the heart block. A popular one in the ECG is given prolonged PR interval or prolonged R2R. So R2R distances are increased. It means what? 1R to another R distances are increased means there is bradycardia, possibility of heart block. Possibilities of heart block. I'll share the ECG file that will show you the ECG findings as well. Now, the first degree heart block, are you expecting giving any treatment in first degree heart block? Not really. First degree heart block, even with the aging, or many cases, there can be showing up, especially aging is one of the very common actually. There is a possibility of first degree heart block things are in the ECG. I remember in case of my grandfather, I'd like to add a very short, it's not history, real life thing. So thing is here, initial days, because of his age, it was always mentioned in his ECG that there are some sort of, heart block, like means PR interval increased or R2R distances are increased. It means there is a fast degree. So my grandfather always used to show me that ECG, like, see, this is something happening. What do you think? Because it's normal. It's nothing to really worry. As the time progresses, he's getting more older, and later I found there was little drop beat. Okay, later there was drop beat. Now, what does it indicate? Is it a first degree heart block, or is that a second degree heart block? Now I can feel the drop beats actually, because first degree heart blocks are asymptomatic. When I realized there was drop beats, so I think like something wrong. Like now it's time. So we went to the cardiologist, and it was detected. Then it was later came up with initially as Morbus type 1, and later he was diagnosed with Morbus type 2. Now, initially there was no pacemaker given when it was Morbus type 1, but later when Morbus type 2 shows up, then the professor, the cardiologist, he recommended, and he probably need pacemaker because his heart is not able to pump in the proper manner as like the before. So that is the reason he needed pacemaker. So initially there was temporary pacemaker, and then there was a permanent pacemaker actually. Okay. After that, like, he was fine for a couple of years actually. Okay, so these are the things, and there is another situation. So for my grandfather, I have only seen first degree and second degree heart block. Third degree, I didn't see that one. Third degree heart block, as per the ECG, is given atria contracting like atria, ventricle contracting like ventricle. Often people make a fun of like this. It's often husband and wife. So one is talking like this and talking like that. So it's like a third degree heart block. So in those cases, again, it's temporary pacing or pacemaker, and there is that later on permanent pacemaker. If you want to add a extra thing here, there's a situation called Stokes-Adams syndrome. Have you heard about a situation like this? Stokes-Adams syndrome. So yes, so in Stokes-Adams syndrome, you also need permanent pacemaker. Strong second syndrome, you also need permanent pacemaker. Okay, so first degree heart block, nothing needed, just reassurance. Most cases asymptomatic. Second degree heart block, Morbus type 1, Morbus type 2. So Morbus type 1, nothing needed, Morbus type 2, you consider for pacemaker. And third degree heart block, definitely considering pacemakers. Now going into the note. That I was talking about. And you see, this is a third degree heart block. It's like a roller coaster, and one is gone. No communication between atria, very high risk of sudden cardiac death. Did you see this? Would you like to take a roller coaster like this? Now, anyone took a roller coaster in their life? Of course, we do. But certainly, if we don't have the lines ahead, we're not interested. Anyone tried in Australia the Gold Coast roller coasters? That will give you feel like that 30-day hard rock probably. You'll feel like there is no lines. Okay, so if you're in Australia, try go to Gold Coast and take that roller coaster. I'm not much interested on that one. That looks really scary. Yeah. The some of them are like, just opposite, they just keep turning like that, So that's really scary. Okay. So anyways, that will happen. P waves and Q waves are completely independent. So ventricle work like ventricle, atria work like atria. Second degree heart block, Morbus type 2. Morbus type 2. And first, Morbus type 1 was also known as Wenckebach. Let me show you something. I know this part looks a little difficult to you now. I'll show you something, it will clarify the heart block, that particular finding. Okay. Okay. One thing about Morbus type 2, your P and R are fixed, and then there is a sudden drops. Again, I'm repeating, this P and R distances are fixed. Then there is a sudden drop bit. Whereas in Morbus type 1, P and R, this distance, this one increase, this one increase, then there is a drop. Did you realize the difference, guys? So in Morbus type 1, increase, and then there is a don't drop it. Right? So PR increased, PR more increased than this drop it in Morbus type 1. In Morbus type 2, the PR is fixed, and there is a drop it. Is it clear to everyone? Is it clear to everyone? Morbus type 1 and the type 2. Often people have difficulties in detecting type 1 and type 2. It's just remember, Morbus type 2 has fixed PR. Morbus type 1 does not have a fixed PR. It gets longer, and drop. Okay, that's an easy way to make you understand. Anyway, coming to the heart block, are you guys ready? Coming to the heart block part, are you guys ready? Starting with the sinus bradycardia. Okay, is it normal? Sinus bradycardia, some cases it can be normal. Some cases, when we are in deep sleep, we also have bradycardia. So it's not like too uncommon actually. If it's symptomatic, then it's troublesome actually. One of the signs can be vertigo, it can be lightheadedness. These are common actually, especially with the elderly people, the bradycardia, it can be. And some cases like athletes, it can be common as well. Now, first degree heart block, as you can see, nothing much significant, except for only little ECG finding, little P and R interval increase. And other than in body wise, there is no symptom actually. So, in terms of treatment, no necessary. Sinus bradycardia also no treatment necessary. First degree heart block, no treatment necessary. Second degree heart block, which is Mortis type 1, longer, and then drop. Yeah. So, usually this one also, some cases are symptomatic, but still we can consider stop the offending drug. Now, question is, which type of drug will be in the history in case of the heart blockage? So I repeat my question. Which drug history you would like to take, especially in heart block cases, like rate limiters? When they limit the rate, limit it too much, and it gives rise to bradycardia, like beta blocker, like calcium channel blocker. So this drug would be in the history. My late grandfather, he also used to take the beta blocker. And then the doctor said, yes, because of your beta blocker, this is the issue. The question is, can we withdraw the beta blocker all of a sudden in that case? So answer is no. Beta blocker is something, if someone is taking beta blocker for some specific reason, you cannot suddenly withdraw it. Unless when my late grandfather, he was having Mortis type 2, then the doctor withdraw that beta blocker and change into something else for him actually. Right? Okay. Because it was Mortis type 2 that time, there was drop rate, there was so much symptoms, so then he had to change it. Alright. Great, clear up to Mortis type 2. So and considered for initially temporary pacemaker, and then later he was given permanent pacemaker. Third degree heart block, treatment needed is a permanent pacemaker. And syncope dizziness are common in second degree, third degree heart block. And a very special thing for the third degree heart block to understand what is that? It's like a Canon A wave. That is a called Canon, JVP showing the Canon A wave. It's classic for the third degree heart block. Third degree heart block. Is it clear, everyone? The heart blocks, third degree, no relation, like husband wife. I mean, one talking like this, another talking that way. I mean, not for all. I mean, fun part. Mortis type 2 has two part. Type 1, type 2. Type 1 is a longer drop. Type 2 is a fixed and sudden drop. Okay. Type 1 does not need any treatment. Type 2 require pacemakers actually. First degree and sinus bradycardia, no treatment required. Okay. Is it clear, everyone? The heart block. I hope it is. Let's come into this particular chart. Same things are written. It's easy. Last but not the least, there's a one last term, torsades d pointis. Have you heard anything like this? Torsades d pointis. Okay, I'll show you the chart. This chart I took from the Davidson actually. It's an interesting chart. Anyone knows the mnemonic? Yes, this is French actually, French word, torsades d pointis. Okay. This is the thing. Quick question, is this related to heart block bradycardia or is this related to tachycardia? Always think about in that way. Is it a tachy or is it a brady? So they said long QT. So anything which is prolonged, anything which is prolonged is related to, more like related to bradycardia or heart block things. Now I remember this thing as A, B, C, D, E. So A for asymptomatic, B for brady, C for congenital, D for drugs, E for electrolyte. Now there's a question often made. This is a popular in the MC, this section. Which of the following is not a cause of torsades d pointis? Okay, so they will mix up the situations and you have to pick up the which is not responsible. Okay, great. Often given in the question, hyponatremia. Please check it carefully and tell me, is hyponatremia is a cause or is not a cause? Not a cause, because all we remember hypo. So I think we also think that hyponatremia probably is a cause, but it is not. Okay, A for asymptomatic, B for bradycardia, C for congenital, D for drugs, E for electrolyte. Good? Great. There's another question tested. It was difficult one, and it was mentioned which of the following drug is not responsible for toxicity pointers. Now you have to remember these drug names. I have a memory, even though silly. It's like Mr. Das, who is a writer of his surgery book, right? So because they're in so much pressure, maybe he developed hypertension, and for that one, he's taking AC inhibitor, Estash. If you remember, read that book, guys, in the MBBS time. Estash, I think, which countries? Okay. So because I think too much pressure, maybe he develops hypertension. So Mr. Das is taking AC inhibitor like this. So why the DAS? Disopyramide amiodarone sotalol, DAS, DAS, ACE. Okay, so Mr. Das is taking ACE inhibitor because he's in too much pressure and he develops hypertension. Okay, I'm not sure, it looks silly, but maybe it was helpful for me to remember this now because it was a tested question. Clear about toxicity pointers, guys? It was the last section from the palpitation actually. DAS ACE. DAS ACE. So talks of this T point is N A B C D E. Thank you. Yeah, it's already given here. See this one. Talks of this D point is the last one. And you just need to see this slide separately. So two harmonics A B C D E and thus it's AC. So thus it's we don't have to remember and it's CC base. Okay, coming back here. So chest pain, arrhythmia. These are done. What is thus? Thus, DS, thus means is a human. Okay. Just take a screenshot, my dear. ACE. These are the drug names too, just to remember. Amitriptyline, brompromazine, erythromycin, diso, amiodarone, sotalol. Thank you. Main part is finished, like the chest pain and the arrhythmias. All good, everyone? All clear? Please comment. I'm trying to be as gentle as possible. I know it's difficult for a lot of doctors for the cardio. Okay, let us move then. So getting into this is slide related to this topic is syncope. So this is like medicine, cardiology, syncope note. So syncope is nothing but sudden loss of consciousness. I mentioned something about this thing early. If you have a syncope, other than the ECG, what one test you want to do? If any syncope cases, other than the ECG, what one test you would like to do is the Holter monitoring. But not all syncope can be similar. There's certain kind of like cardiac syncope, neurocardiac syncope, then like epileptic type of syncope and postural type of syncope. Now, this chart can be very useful for you. Cardiac syncope, neurocardiac syncope, and the seizure. Okay, as you can see, looks couple of them similar, lightheadedness. Seizure epilepsy, understand, and seizure epilepsy, we do have a lecture on the pediatric. Uh, but one thing is initially interesting, um, lightheadedness, syncope, all this thing. Cardiac syncope cases, they have pre-existing cardiac problems. Okay. So we'll share a ECG. So in that case, you can overcome that problem by seeing that ECG. Already mentioned about it actually. You have ECG problem because your MPBS ECG reading is not properly well. Okay, so we cannot help you that much, but we can help you with the video, which is necessary for MC. So ECG is a big field. So there's this two way you can study. One, you can read whole big ECG books so that you can become a very good cardiologist or whatever. And another way, whatever needed for MC and relevant things. Yeah, so that's the thing. Yeah, I don't recommend any books actually, to be honest. I mean, it's a huge time consuming. Yeah, so whether you see that video, then what is necessary for MC and quick diagnosing. I mean, see, ECG think as more like pictures. I mean, I can see a lot of people also take classes only on ECGs actually. I feel kind of funny on that one actually. It's like more think as like picture. If you see that picture, do you really understand this picture indicates what? It's not that rocket science like ECG. If you know like what is the normal and the abnormal, you can just find it out immediately. Okay, so that required seeing many more ECGs. You can be an expert on reading a whole book, but you may not be an expert real life ECGs. Did you understand what I mean? If you can be expert, oh my god, this book I have read this, but in real life, if you go, you can't read ECGs. This is reality. Many people have seen, okay, oh my god, they're taking classes on ECG, like 10 classes, 12 classes. Many students have seen interns, okay, read this ECG, sir, okay, like that. Think ECG like a picture from now. Okay, so you can just quickly. So check the video, which I will be sharing shortly after the class on the ECG, and then check 5 to 7 or 10 different ECGs from the Google related to that. Because these are most common diseases which usually you be encountered with cardio actually. Even not only for the MC, even in real life actually. So your ability will be asked, can you make a quick diagnosis by seeing? Because minute means muscles in cardiology. Alright, so this is the thing. Same like the histology, seeing the slide, making a quick diagnosis, that matters the most actually. Great. Come to this point about the syncope. This is the chart. I want to highlight this chart about the about dizziness, syncope. These are common, of course. Cardiac side has a pre-existing cardiac problem, like they have chest pain histories or previous MI histories. And there's another thing, recovery period. Now, cardiac recoveries are faster, or do you think the other syncope recoveries are faster, like say epilepsy? In a situation like epilepsy, there will be epileptic syncope, and then they are very confused after coming back. When in cardiology, they are suddenly syncope, you get DC shock, CPR, suddenly they came back. This is fine. Okay. You said you're alright, okay. Yeah, they get it. But after the epileptic period, even if you tell anything, they will not understand anything. Okay, so this is also known as post-ictal confusion. Yes. Right? So here you go. It can be quite prolonged in case of the classic seizures cases. Prolonged confusion, the minimum is more than 5 minutes. Maximum can be even 30 minutes here. And there's another one, neurocardiogenic. You can see. So again, slow. So the faster one here is a cardiac syncope. Now, popular in the exam, what do you mean by neurocardiogenic syncope? It's more like situational. Have you ever realized when you are coughing too much, some cases, too much cough, in that case, you might feel a little dizzy after, too much cough, like Maybe all of you have gone through cough in your life. Yes. So this indicates some neurocardiac because you are using that reflex. So unconscious after violent cough. So this is neurocardiac syncope. Okay. There's a most popular in the exam, which is a 5-star for MC, actually vasovagal syncope. Went into marketplace or medicine wards. Whenever we go to the medicine ward in third year, I saw some people fall down because of everyone has to, stand and write things, right? Or playing for very long term and fall in the ground actually. So very long, prolonged standing, and of course the shopping. Don't forget. And last batch I was telling that, is this thing happened with anyone, any female? They said, no, sir, like, we are very smart. And when you go for shopping, we eat before we started shopping. Oh, okay, makes sense in that case, right? Okay, smart people these days, actually. So, standing in marketplace, shopping, public place for a very long time, cricket field, if you are playing cricket for a very long time, it's possible. Morning as only is not much time, honestly. Yeah, OT rather than operation theatre. I have seen one of colleague falling down actually. Yes. So here's the thing: prolonged period of standing can leading to this particular type of syncope. Often because of like they haven't eat properly or drop in the sugar levels and this that actually. So prolonged standing can this thing to happen. So a patient become unconscious after prolonged period of standing. What type of diagnosis it is? Vasovagal attack. It's interesting. Another question in MC, temporary LSC, asking which step help you to make a diagnosis. A lot of things are given, but B, according to like John Mukta and Davidson medicine. Is it important to ask the witness? Because some syncope can be fake as well. What do you think? So this is important. So ask the history of the witness. Also, the witness can tell if there is any other symptoms there actually. So here is a John Davidson line. So any syncope cases, asking the witness is number one. Asking witness is number one. Okay. So first B, then A. There is a few spatial lines. Sorry. First time seizure. First time seizure. It can be happen with any one of us. So will it be because of a blood glucose or will it be more chances for electrolyte? What do you think? It's more chances because of electrolyte. Anyone can have seizure. So children coming with a seizure for the first time, it's not blood glucose, it's the electrolyte checking. If it's a recurrent seizure, previously also admitted because of seizure, then you don't go for electrolyte, then you check the blood glucose level first. Now, many people answer, I'll teach you these things in pediatric again. They go for the EEG for seizure cases. Is it a right answer initially? Of course not, actually. EEG, even many cases, they don't even perform. Even having seizure, they don't perform EEG many times. So EEG is a long shot. So EEG will be done much later after confirming the initials like electrolyte, glucose, and all these things. Some seizure cases, EEG can be done a little early, like absence seizure. I'll teach you this part in the pediatric. Absence seizure, like a vacuum loop, starting into the step, but the patient is stable. So in those cases, we can go for an EEG. Yeah. A quick question, even though we have an emergency related class, but a quick question, a pulseless patient, what you want to do next? Would you like to give a DC shock first, or IV fluid first, or CPR first? Answer, a pulseless patient is always CPR. And then in between that adrenaline tickles, you can see the format necessary. Okay, this is the case. You can see 75-year collapsed in a garden, can be any reason, and recovered 30 minute blood pressure this and systolic murmur. So the person has a collapse and a murmur at the same time. Activity is reduced lately and maybe having fatigue because of old age, but it's a definitive investigation. So they ask about a definitive investigation here. Please note the person is having murmur. So is it a physiological or pathological, do you think? 75-year person is having a murmur, it's definitely pathological. 1 year kid is having murmur, it can be physiological now. This is pathological, certainly. And they ask you about the definitive investigation means confirmatory investigation. So can it be ECG or can it be 24-hour ECG? Please mind it. They didn't ask for initial. So they're asking whether for, yeah. So this one with a very old age, falling down, its higher chances can be aortic stenosis because of the systolic murmur. So it's a answer is a echo. Senile calcification, often you see in the echo it is written senile calcification or calcification. If you do any um, echo or if you have seen any echo over 75 years, you see there's a term written calcification. Have you noticed that? Many echo it is written calcification or senile, so it's very common in them. It's often it's progressing towards any aortic stenosis or any other stenosis. Okay, clear everyone about this particular note? So syncope is done. Syncope is done. I won't take much time here. Yeah, so I'll be finishing shortly. So, yeah. I'll take you to a different page now, guys. It's actually infective endocarditis. It's much easier to you guys. Do you need 2 minute break or let me just finish? I don't take much time, so don't worry, guys, actually. By the way, I'm taking this class from Turkey, actually, Istanbul. I think anyone staying here, I'm not sure actually. It's, Istanbul is not popular for like AMC, I guess. Yeah, Istanbul is not like people from here mostly they prefer going to UK because it's more nearby. Yeah, great. Okay, infective endocarditis. That's the particular now. The infection of the heart valve. Okay. Infection of the heart valve by any means, by a dental surgery, by a heart valve defect, or a foreign body, by any means, this infection comes that goes to the heart valve, and then there is a vegetation in the heart valve, eventually leading to infective endocarditis. Alright. Now, in infective endocarditis, there's a few special lines. Young male, maybe IV drug abuser, young male with fever and murmur, young male or young person or young with fever and murmur, suspected infective endocarditis until proven otherwise. Okay, very important. Great. Let's few lines in previously heart valve defect, IV drug abuser like a foreign body were entering, or previous history of heart issues, heart valve defect, aboriginal, rheumatologically involved aboriginals. So, anyways, the very important thing about some of these infective endocarditis is, let me show you something. I think we have a note here. Just give me a second. No worries. First of all, like As I mentioned earlier, microbial anything is important for AMC exam. Example, if you will be asked what is the most common cause, what is the most common cause of infective endocarditis? Answer would be viridans. Answer would be viridans. So please highlight this one. Then you will be asked uh, which one is more common in prosthetic heart valves. I repeat my word. Prosthetic heart valve, which one is more common? Answer this epidermidis. Okay. Epidermidis is common for the prosthetic heart valves. And IV drug abusers, Staph aureus is more common. IV drug abusers, Staph aureus is more common. Is it clear, everyone? So most common viridans, then prosthetic heart valve users, epidermidis, and IV drug abusers, Staph aureus. Okay, already mentioned. This is most common. Pretty easy, guys. Can follow. Staph aureus. Just draw a heart valve. Staph aureus. Yes. IV. Just write IV. Okay. Page number 190. Okay. There are some clinical features of infective endocarditis in next page, 191 page. Certainly given, starting with the young person, IV drug abusers, and in the heart there is murmur. This is classic. But there's some organs also involved, like splenomegaly is common, and there's some findings like Osler's node, January lesion. Okay, there are certain terms like that for. We all learned this thing in MBBS levels actually. Osler nodes are, by the way, painful nodes actually. Osler nodes, Osler pain. Sometimes we used to make fun. Now, come to the investigation. What are some of the investigation related to infective endocarditis? Guys, come on, we need to wrap up. Okay, I think some people know it already from the beginning. Infective endocarditis is a very easy MBBS topic. So guys, let's participate so that we can finish it. Okay, good one. So we can go for CBC. CBC, further confirmation please. CBC with yes or further confirmation by a blood culture. Because a microorganism entered, so you need to rule it out by blood culture. Is that so? Is that how you confirm? No. We need to do further confirmation by an echo, transesophageal echo. Again TOE. Last time we see the TOE in the aortic dissection. Again here, transesophageal echo. Okay? Transesophageal echo. So CBC, blood culture, transesophageal echo, and of course we also do the ECG to rule out if there is no other underlying condition. Is it clear about the investigation? So CBC and blood culture, further confirmation by an echo. Is it necessary to give antibiotic in infective endocarditis? Of course it is. Just definitely. So benzyl penicillin, gentamicin, and these antibiotics are highly recommended. Highly recommended. Now, is it always necessary that all infective endocarditis cases have required antibiotic? Is this statement is true? Is this statement is false? All infective endocarditis cases require antibiotic. Answer is false. Okay, it depends on is it a low risk or is it a high risk cases. High risk cases like prosthetic heart valve, congenital heart disease with mitral valve prolapse with regurgitation. So this type of more sensitive cases are considered as a high risk. So more high risk cases, prophylaxis. You mean to say prophylaxis. Yes, thank you for correcting it. So one is the acute case. In the left hand side, this is a treatment for acute case. Already established infective endocarditis. And another one is you must be knowing about rheumatic fever cases. So in rheumatic fever cases, prophylactically antibiotics given for a long time. So those cases, we need antibiotic or not. It depends on the low risk or the high risk cases actually. Especially if rheumatic fever with the feature of carditis, you need to give the antibiotic even till the age of the almost 20 years actually, if associated with carditis feature actually. Okay, so you can see, yes. Alright. Certain other antibiotics can be given before some procedures, like say dental procedures. You might need to give prophylactic antibiotic. Another procedures like genitourinary procedures. Some of the genitourinary procedures, like say amoxicillin, yes, these particular antibiotics are recommended. For genitourinary, oral, these are necessary. Is it clear, everyone? The preventive or prophylaxis of infective enterocolitis is already given here. Low risk, high risk, and the antibiotic. Dental cases, genitourinary cases. Low risk, like isolated cases, means no prosthetic valves and this that. High risk cases like prosthetic valve, congenital heart disease with more difficult situation. So those cases might require prophylactic antibiotic. Alright? I hope. Again, left hand side is for the who already developed infective endocarditis and need acute treatment. In the right hand side, the future development cases are prophylactically these particular things. I'm sure you can do a little bit more research on that and you can figure it out actually. Alright. So this is about the infective endocarditis. Okay, so 1, 2, 3, all these things are done. Alright. All good, everyone? All clear? Okay. Today's last topic would be the heart failure. It's the most easiest topic. Even though originally it's quite a complicated. Basically, you need to learn acute heart failure versus the chronic heart failure. So I'll take you to the SMA note section for that one. It will be much more easy to tackle the situation. Mainly, the management of heart failure comes in the exam often. Just give me a second. Okay. Are you guys alright so far? I mean, understanding, I know it's a little difficult. Still, some people will say it's a little difficult. Yeah, but that means during cardio, you might need a little bit more study. Okay? Because the problem remains from the early life of our MBBS. So we need a little bit more study in the cardiology field. Okay? In order to have a smooth MC exam. Okay, heart failure is more like a congestive heart failure, and heart valve cannot pump the blood properly. Often because of a age or certain conditions can lead to heart failure actually. So acute heart failure, chronic heart failure. Now, right heart failure, congestive failure, three conditions. We all know about it, raised JVP, edema in the dependent part of the body, and the hepatosplenomegaly. Okay, but think all these things as more like a traffic jam. Okay, think all these things is more like a traffic. You can see these pictures in Dhaka. This is very common. Now, three things happen in a heart failure case: increased preload, increased afterload, decreased contractility. So when you give a drug, basically you try to decrease preload, decrease afterload, and increase the contractility. This is the main motive actually. Now, when you have a heart failure, you know what happens? Say maybe this side failed. Then as the vena cava, which is supposed to bring the blood and circulate and go away, it's not going well. So this pressure developed. Then this pressure goes to the liver, and eventually there is hepatosplenomegaly because of the portal issues actually. Okay, so in a way it's more like a traffic jam. It's more like a traffic jam. We have a right heart and we have a left heart actually. Because of the left heart, your right heart also can be involved often. Remember this. Okay. If you have a left heart involvement, say mitral stenosis, last day we discussed left heart valve involved mitral stenosis, is it possible to have pulmonary edema in that case? If left heart is involved, like mitral stenosis, because the blood is not coming, pressure development in the pulmonary vasculature, like pulmonary hypertension, leading to pulmonary edema. So it will be associated with breathlessness, cough, nocturnal breathlessness, all these things. It's all because of the backflow. Yes, you are right. Again, preload, afterload, contractility. Again, is a little difference between right heart and the left heart. Some of the things. Left heart involve the pulmonary thing. I repeat, left heart involve the pulmonary things. So there will be more breathlessness, more nocturnal features are common with left heart. Why? Because with the left heart, if there is a traffic, your lungs will be involved. But with the right heart, directly lungs are not involved because it's affecting the vena cava. More features on the JVP, vena caval pressure increase. Is this clear, guys? I mean, it's not a very difficult one considering the MBBS, like which part is affected and eventually leading to liver and all these things happening. Okay. We started with X-ray. We started with X-ray ECGs. This is common, but gold standard is echocardiography. Everyone agree? Gold standard for heart failure is echocardiography. There's some also more investigation mentioned, but if you remember these three, it will be enough. Have you ever heard about this kind of thing? There is left atrial pressures, some cases tested. Like that is called the cardiac catheterization. Have you heard things like that? Like so, X-ray, echo, and cardiac catheterization. The catheterization can be another way to make a like diagnosis. Okay. Now, management of acute heart failure. You can see. Now, which one do you prefer for acute heart failure? Diuretics or beta blocker? Which one do you prefer for acute heart failure? Definitely Lasix. Most people say like diuretics. So, in acute cases, even beta blocker better not to give. In fact, when the patient is stabilized, then we consider the beta blocker. So you can see diuretics is the mainstay. And when stable, then you consider beta blocker. But if unstable cases never give beta blocker, it is contraindicated. Why? Because it will decrease the contractility in that case. So also you can give ACE inhibitor and the digoxin. One time tested topic, some of the digoxin related side effects. So please check this one. They also can cause visual disturbance. This was the thing was tested in MC in past. So digoxin can lead to visual disturbances, including electrolyte imbalances, including potassium can get involved in digoxin toxicity. So digoxin is also involved in chronic heart failure cases. Acute cases mainstay is a diuretics. Up to this, is it clear to everyone? Acute heart failure management, chronic heart failure management. Acute heart failure, left heart failure, and the right heart failure differences. An investigation related to heart failure. So our last particular thing is here, acute cases, diuretics. For stabilization or decreased mortality, we can use the ACE inhibitor later. And we can go with combination like AC plus beta blocker. Later we can use the spironolactone type of things if needed. Alright. I hope that's clear regarding the heart failure. So the management of heart failure is also given in John the 898 page. The 898 page. You can just mark it, but if you see the assignment note, it's also fine actually. It's only the 898 page will be important for you. All right? Great. And the hypertension is the next time topic, but hypertension thing, it's most easiest one. Hypertension, I think in my YouTube channel, there is also a hypertension related relevant video. You can also have a look on that one. So what you can do in YouTube, you can type hypertension and type my name, Share and Shuja on YouTube. You can find that section. All right. It's easy peasy one. I mean, not at this point now, something to discuss. So hypertension is most easy, primary and the secondary hypertension, and its relevant diagnoses and antihypertensive drugs actually, and some of the antihypertensive drugs actually. But next time when we start up, we'll definitely talk about the hypertension a bit actually, especially antihypertensive actually. I hope you thoroughly enjoyed today. I mean, I know it's a little difficult, but good luck to all of you. And I think you can take the, yeah, cardios are a bit long. And what you can do, you can go and take the mock now. It's better usually time to time if you finish things. So mocks are posted if you can check. And good luck to all of you. Thank you so much for attending the session. JIT mock, I think it's posted. If you can check, anyone can check and confirm. Okay. Singapore. Anyone can confirm? Yes, posted. Yeah. Great. Yeah. So see you guys tomorrow, hopefully. I mean, with another class. We are back to back classes. Tomorrow is cardio theory 2. So the theory 2, what's coming up is the next, this particular topics, easy peasy ones. Yes. So here we go with all the things. Yeah, tomorrow again, because this cardio is little, yeah, in one class if you try to compile, so it'll be too much. Please note one thing in cardiology, tomorrow's class, it can be 1 hour earlier than usual, but I will confirm it in a group actually. Yes, I'll be able to upload the recording actually. So tomorrow we might be starting 1 hour early because I'm already outside from Bangladesh, so it will be little easy for me if we do it 1 hour early. I'll be uploading in the group actually, the time. Okay. See you guys. Thank you. Yeah, tomorrow class and also the Thursday class. Yes, I'll be posting the recording today after 1-2 hours. Thank you. Good night. Please take the JIT mock now. My humble request. Good night.